any acute or severe or chronic illness and how it affects the system at large. So how can we achieve improved outcomes, and what does that mean when we're talking about people with cancer? For the perspective of clinical researchers or outcomes researchers in oncology, there are three. We look at enhancing quality of life after the diagnosis, but we also look at how can we better utilize healthcare? How can we deliver more quality care? In fact, there is this huge emphasis right now, particularly in breast as well as in gynecological malignancies, to choose wisely. It's a big campaign. And part of the things that we are looking at is, does a 90-year-old woman with a new diagnosis of breast cancer, does she really need a sentinel node biopsy? For people with ovarian cancer, do you really need to follow them every 3 months with blood tests? And these are all based on data suggesting outcomes may not be impacted with further tests or more tests. And ultimately, what we want to do is see how can we improve the systems of care to improve survival outcomes while we are all trying to improve the therapies to improve outcomes. So in this vein, this is where patient-reported outcomes has really come into it is maturing. It hasn't matured, but it is maturing. So the FDA definition of a PRO is any report that comes directly from patients as it relates to the health condition or to the sequela of its treatments. If you think about how this plays out, it wasn't called PROs when I trained. It was called the review of systems. Someone came to the visit. You took a review of systems. You asked how they did. You asked the 7 characteristics of the symptom. If they went to the operating room, a quality metric or quality maneuver that's done at lifespan is there's a follow-up phone call at 24 hours of discharge to see how they're doing. And then we also provide instructions. So much of this expects nothing of the patient, right? They are looking to us to reach them, and they will respond to us. It's almost as if the wall is there and they cannot bypass the wall. They have to wait till they're invited. PROs reverses that. And certainly with digital strategies, it should make it easier to provide self-report with automatic prompting. Now, I thought this was fascinating in terms of the historical perspective from patient-reported outcomes. The first publication using a PRO was in 1976, but it wasn't until 1992 that phrase, that term, was actually recycled in the literature. In between, you had health-related quality of life coming in. But if you look at the milestones of PROs as a research question, in 2001 is when the World Health Organization adopted this international classification of functioning disability and health, which really, in reality, is speaking towards the signs and symptoms we can collect with PROs. In 2004, the NIH funded something called the PRO, Patient-Reported Outcome Measurement Information Systems, PROMIS. It was headed by my colleague David Sella from Northwestern. The aim was to develop a validated, reliable PRO set that all healthcare researchers could use. This was not and is not a cancer-specific tool set, PROMIS. It's available online even now. In 2014, there was this trend that picked up steam that said doctors and patients shouldn't be in the position of being the parent speaking to a child. Really, it must move towards more patient involvement in their own care, and it culminated during the Obama's administration in the establishment of the Patient-Centered Outcomes Research Institute, or PCORI. So again, this is not a new phrase. This goes back decades, but really it's come into fruition in the last 10 years. So it is also considered PROs as part of this whole health ecosystem. And I like this graphic from the IBM Institute for Value, because what it says, everything we are and everything we do as both public health experts, healthcare providers, clinical research centers, all of us operate with the patient in the center as a consumer. So all of our efforts are in terms of trying to improve outcomes for those we seek to help, but we cannot do it without them informing our efforts, no matter how we get to it. These patients want to know and want to be involved in the care, not only at the individual level, but oftentimes these quote activated patients form these communities now widely available on social media where they are becoming experts in their own rights. So the question then becomes, within oncology, can PRO collection improve outcomes? This was a seminal study that was published 4 years ago, and it was actually so important that it was a plenary presentation at an annual meeting of the American Society in Clinical Oncology. Ethan Bash was a fellow who trained with me at Sloan Kettering. He did this study within Sloan Kettering. He enrolled over 750 people with metastatic cancer receiving chemotherapy. The intervention was electronic prompted self-report, and the comparison was usual care. So in this first graph in the middle, what you're seeing is an improvement in quality of life among those patients who self-reported. It did not become worse, and in fact, there was a 16% improvement in their quality of life because they were engaged in their care. They also saw a significant reduction in emergency room visits, a trend towards reduced hospitalizations, and a significantly improved time on therapy. What was even more striking was this graph on the right. Median overall survival was longer by 5 months among patients who were self-reporting. It might have been because they were able to stay on treatment longer, and that we as their clinicians were able to pick up on their complaints earlier before they became as severe as to require hospitalization. But this survival advantage was significant. Now, if this were a drug that produced a 5-month improvement, this would be automatically standard of care, FDA approved, and everybody would be using it. So the clinical significance endpoint for therapeutic clinical trials is about 2 to 3 months. So this almost doubled that. Now, despite the fact that this study was published in 2016, the field has not moved to the routine collection of PROs within centers. And why is that? There are some roadblocks that have come up, which are very difficult to solve unless everybody wants to get involved and really crowdsource the solutions. So the first is the data comes from places like Sloan Kettering, major academic centers where they have internal self-developed EHR systems. We're better equipped to develop their own personalized PRO system. Not only that, they were able to operationalize it because I could tell you every single oncologist treating solid tumors at Sloan Kettering, and I could also call them and get them involved in my project. It was literally a family at Sloan Kettering. You're also seeing this effort in the cooperative group level, where it is a larger community, but in order to gain access to those PROs, you have to be a part of it. And we have 5 cooperative groups within the United States. They don't all interface and they don't all use the same PRO system. Access to these tools then are limited, and there's community barriers, institutional as well as national barriers. Most of the PROs which have been validated are in English. Some of them are in Spanish. There's very little beyond that. In fact, if you have an Egyptian patient, it is highly unlikely you're going to have a validated PRO for them to use. Electronic health record systems are variable, and I'm going to bring that up again when I talk about our own SIMPRO project. But if you look just here in Lifespan, the Department of Medicine is not on Epic. Neither is University Surgical, Brown Surgery. We are on Epic at Lifespan Cancer Institute. doing a collection tool that goes lifespan wide is limited because we have multiple record systems in play. This is another report. It was from Heath and showed other things. The term she was using is patient-generated health data, PGHD. 30% of patients say that if you gave them access or the ability to generate their own health data, they felt more engaged. In fact, 35% said they were, more engaged versus much more engaged. That leaves 40% of the population who don't feel this way. The roadblocks that they were able to document, either it's overwhelming for a sick person to do this, it's cumbersome, and it's time consuming. For providers, we are concerned because the data isn't clinically relevant. So despite the fact that we have the BASH study from Sloan Kettering showing we could improve outcomes, there are still these barriers towards implementation. So this is where the Cancer Moonshot Initiative came in, working towards a wider adoption and implementation of PROs. The Moonshot Initiative is otherwise known as IMPACT, improving the management of symptoms during and following cancer treatment. It's a collaborative research consortium funded by the Moonshot. The goal is implementation. So this is not a proof of concept. This is an implementation project to set the foundation for effective, scalable, and sustainable management approaches during a routine cancer care. So taking it out of the research side of things and focusing into how can we do this across the country. This is the impact centers. So the Research Triangle Institute is the coordinating center. There were only 3 impact sites approved. One is at Northwestern, one is at Mayo Clinic, and then the Dana-Farber SIMPRO Research Center was also approved. This is SIMPRO. So we are part of a healthcare organization program with Baptist Memorial from South Carolina, Dartmouth Hitchcock, Maine, West Virginia. What binds us all together? The use of Epic. So the partner that was important to make this happen was that we were all part of the same electronic health record system, Epic. The second thing that was important about SIMPRO, we all represent very different constituents. Baptist Memorial being predominantly Black, middle to lower income class, Dartmouth Hitchcock very rural, West Virginia similar. We are urban, South Shores community, and then there's Maine. Now, we are also very different from both the Northwestern and Mayo Clinic sites, in which, and I'll show this later, we are doing both a surgical phase in SIMPRO and a medical phase in SIMPRO, trying to expand the use beyond patients receiving palliative chemotherapy for cancer. So here's the electronic symptom management program. My co-investigators at Lifespan are Tom Miner from surgery and Christina Bandera, and it's being led by Meg Begnosh. I'm going to just show you. And the reason I'm showing this to this group and for everyone here is because this is now our PRO system. So this is not LCI or SIMPRO's PRO system. Once we work out the kinks, this PRO system can be accessed by anybody who wants to collect PRO data. So eSYM is integrated into Epic, and it allows tracking and reacting in real time for patient symptoms. The aim is to decrease hospitalization and improve symptom management. These are the symptoms that we cover. There's 14 of them listed here, and we are using the patient-reported outcome system based on the adverse event system that was built by the NIH. It queries folks and gives them summary scores for severity of symptoms. This is what it looks like. There are both pictograms as well as text and what it looks like. And this is how eSYM is assigned for us. And like I said, we have both a surgical and a medical date, or medical cohorts that are being asked. and the system is to set up and designed to deliver over 8 weeks. So surgery, we're looking at patients who had an operation for GI, GYN, or thoracic cancers, and in medical oncology, patients starting a new chemotherapy regimen in the same 3 groups so that we can better identify these cohorts in terms of an efficacy analysis. So this is how eSYM is operating from the patient side. They get automated notifications to their phones. The questionnaires are sent between clinic visits, and it's coupled to self-management tips. There are alerts of severe symptoms that come to us as their clinicians, and they have the ability to trend their symptoms themselves. So in terms of how it works, they have to be online. They have to have downloaded MyChart. So all of this is not going through their text or their mail function. It's coming through MyChart. They will receive a notification, sign in, and eSYM is now showing up on their MyChart and Epic screen. So what does it look like when they sign in? They will come in and they begin answering these questionnaires. And this is what it looks like on a phone. They submit. And if they've reported severe symptoms, they're asked to call their doctors. On the desktop, it's a gateway message, similar thing to go into lifespan. And just like in Epic, which we either love or hate, there are many ways that they can get into eSYM. These are both the same, and it will get them through. They answer the questionnaires, and again, it's similar. So again, it's built to be operational on both a smartphone and a laptop and a computer. And they can also have one way to look at their answers before it's submitted. And then it takes them to this tip sheet, which brings them to specific symptoms that they reported and how they can manage it. And it also shows them the library of things. I will tell you that all of us involved in the project had the ability to both review and edit these tip sheets and make them relevant to our populations. Again, just a small example. Here's a wheezing one. If these clickable buttons will take them to videos and other screens. And then what happens afterwards, the clinicians get notified. And if it's a severe symptom, the in-basket messaging system is triggered on the clinician side. So one of the questions that came up, does the patient have to do it? The answer is no. There can be either proxy reporting where the patient just uses or the caregiver uses the patient's login to do it, or they can request their own login screen as a proxy. So again, the primary goal is efficiency and the management of symptoms. And in terms of what we see, we can see the individual level all the way up to what is the entire cohort reporting, which I think is going to be really useful when we're trying to track this on a population-wide basis, maybe stratified by surgical type or by chemotherapy. And this just shows the dashboard, which is the clinician's view. To explain it more, this is a total of people who are on the registry. So this is triggered by your eligibility criteria, for example. And of that, this is the people who have signed up and downloaded MyChart. These are the people who actually use it. These are the questionnaires you assigned. These are who don't have it. And then how many responded in the last week. So you can actually see utilization of the SIMPRO program. You can do reports from the entire cohort of people just to see if there are trends. You can also do individual summaries, and you can track how these look over time. So again, a pretty functional tool for both clinical use as well as for research purposes should you need it. Just to go forward a bit, this is just a flow sheet view. If you looked at labs, it's the same kind of concept. So this is how they rolled out across all of us. So it wasn't a time point zero where all of us were timed on. It was a stepwise fashion for both medical oncology as well as the surgical group. Lifespan just turned on in October, and we started in surgery. We'll do medical oncology later on. And this is an example of an implementation sciences project. So the population was here, the intervention is SIMPRO, control is without. So everyone who meets this very broad eligibility becomes part of the registry. Half of them will get prompts, half of them will not. And the outcomes are hard data: emergency department visits, hospitalizations, burden, and then we're going to query for care satisfaction, as well as whether or not this was useful or not. It's a 3.5-year study across 6 systems, and the design was a type 1 effectiveness implementation project building on something called the Consolidated Framework for Implementation Research. So I thought this was fascinating. I'm actually on the Impact Implementation Sciences Working Group, where we are looking at all of these and trying to find, will we be able, at the end of this project, to summarize characteristics, settings, and the patients and MDs in a way that is that can be uniformly concluded across 3 research centers. But I think this is a really great way of looking at rolling out a new system or program in a way that makes sense and hopefully will lead to uptake on a larger scale. So I do think that these have implications beyond oncology. We now have, at Lifespan, an Epic-built patient-reported outcome system for use that is not restricted to a clinical research project. We are live in the surgical setting. We meet weekly as a group. We meet monthly with Dana-Farber and the Research Center, as well as the 4 other sites. We will go live in medical oncology later this year, and this will be available. And we're working out with IT about what that request process would look like. But it's literally, for them, it's just turning it on for other investigators so that your own queue of patients automatically populates via Epic. So in conclusion, patient-reported outcomes are a measure of patient-generated digital health. These have been shown, at least in the oncology setting, if routinely collected, to improve outcomes that matter to anybody within and outside of oncology who are interested in healthcare utilization. They can show improvements in overall survival, and we just need to meet the challenge of how to get this more widely available to patients, because, as was also shown, if you build it and if you ask them to do it, patients will participate. So with that, I will close.
Thank you, Don. That was terrific. I really appreciate both the work that you've clearly put into creating the system and to the attention to patient-centered outcomes, which is ultimately how we get folks to engage. So I will open up for folks to ask questions. Feel free to just kind of unmute yourself, or if you prefer to not talk, which I know many do, you're welcome to also post stuff into the chat.
Hi, Megan. I'm Roxanne, and I've worked with Don for years now, and he's always doing creative and new things for his patients. So, Don, I wasn't even aware you were doing this. Currently, I'm the director of blog, and he's got his hands in a lot of things. But I do have a question. The go live, when you do that, do you foresee this going into other languages for our diverse population in Rhode Island?
Right. You know, I think that's the major issue regarding PROs. And again, it is a stumbling block. If you look at the availability of quality of life questionnaires within oncology, there's only a few validated questionnaires that has done the efforts and done the work in getting them validated in different languages. And as you know, anyone who's more experienced in generating these questionnaires, these patient-reported outcome tools, the validation step is just hugely critical. So as of right now, the limitation to rolling it out is the availability of the questionnaires in the languages. But I know that is a huge, huge issue that both Promise is tackling, and that we will as well. But the answer is right now we're not doing it.
I do have one more question if no one minds. So I'm in clinical research and I'm listening to all this. And in those patients that you're enrolling at this point, are any of them on clinical trials, and has that benefited the folks that are assessing toxicities and dose reductions, et cetera?
No, all of the patients that are so far enrolled are just being discharged from surgery. So the answer would be no. Now, could this be used as a clinical research tool to prospectively collect adverse events on a clinical trial? The answer is yes. And we know that, the history of clinical trials and grading toxicities is that investigators notoriously grade down toxicities and don't collect the ones that patients are truly experiencing. The only way we can use those adverse events is we know that this is across the board the case. Yeah. So there's nothing specific to a trial. Now, what has been shown with more proactive data collection, like the use of PROs, is that you get more AEs, you get the AEs that are relevant to patients, and you get a better idea of their severity.
Thank you.
I have a question. So I'm wondering if, and the reason that this is on my mind is honestly trying to schedule the vaccine for my elderly relatives. And I'm wondering if you have any experience with sort of the learning curve of technology and people that don't necessarily know how to use an app like this, or how to, like, even what EHR is, and like how you've dealt with that.
Yeah, so that's been a big thing. I think probably all of us who are in clinic, we've had to really, ask everybody to get my chart on their phones. And when I went around and talked about this project with our patient family councils at all the major hospitals, one of the things that came out was, older adults don't have phones like this, and B, they don't know how to use this kind of technology. So the circuitous way around it was twofold. Number one is to actually sit down with somebody during clinic or discharge and download the app with them, not for them, not, to send them home with an instruction sheet, but actually put it there with them. That was number one. But number two, what came out from the patient family council was allowing proxies to go in and fill these out for them. So I think that's what happens a lot when, I know I do this for my parents, and they're my mom who's in Hawaii. I will actually go into her e-chart, look at lab work, and query her clinicians, and then he'll respond to my mom. So I think that's one thing that our patients were telling us, is that, I might not want to do this, but I want my husband to do it, or I want my son to do it, and he lives at home and he takes care of all of this stuff for me.
Awesome.
And relatedly, have other folks rolled this out?
They haven't rolled it out outside of the project so far. We've actually been, there's interest in palliative care to better monitor symptoms in that group. I think what's going to be more important, and what we're working on now, quite frankly, is trying to see if the catch in that denominator is accurate coming in, because that's really critical. And we're doing a lot of problem solving with Epic regarding that. It's interesting how, even though we're all on Epic, all of our systems, how different the builds are per organization. So that little kink has actually been really problematic.
That's super interesting. I'm sure that you remember that kind of during the Ebola crisis, that Epic put in some kind of standard screening measures, but because of the hospital by hospital adjustments to their builds, it messed up their algorithms, which is the way that the guy in Texas who had a fever and had traveled and actually ended up having Ebola slipped through the system, was because of these little kind of inconsistencies. And it's, of course, the data. One of the challenges that we have with data harmonization, even between like our emergency department and inpatient data, when you try to match them together, the way that we record blood pressure and weight is different. Like, there's like these ridiculous aspects to it. So that's
it was interesting, at other institutions where Epic is throughout the organization. Every person identified had a visit encounter that was a key. So it was a pre-op visit with their doc that was built on Epic. Now the surgeons, so we need to figure out a workaround, and we had to tie it to pre-admission testing. And then, so now we have to do, okay, give me a list of all your surgeons who underwent pre-admission testing with these codes, rather than saying, you know, university surgery or surgical oncology with a pre-op visit. That's going to be your thing. It was much more difficult for our system, and we're still trying to work through some things.
I'd be interested also, Don, to hear about your experience with getting IS and IT to work on this. So one of the things I know that we've, and I don't know kind of some of the folks on this call, but one of the things that is kind of this constant balance is that certainly at Lifespan, but also at many health systems across the country, ISIT has really limited bandwidth. And so they're often challenged in terms of taking on things that have greater research importance, as opposed to and kind of there's that kind of clinical versus research push-pull. And what I'm hearing from this is this is both research and has immediate clinical value. And I can also imagine from Lifespan's perspective, they're thrilled at anything that increases the percentage of people that are using MyChart, because we overall have relatively low rates of sign up for our patient portal, not compared to other institutions, but just as an absolute number. But I'd love to hear a little about that process if you're comfortable sharing.
No, absolutely. You know, so as part of going in for the grant, one of the biggest asks from the coordinating center at the Farber was to identify who are your point people within IS at Lifespan who's going to work on this. So that was one of the first things that we went to Cedric Prevey with, was there's this project, it's on PROs, blah, blah. I need you to identify people. So those folks were not just told, hey, there's this project and you need to do it. We went through this whole, I think you're on that council where we actually reviewed all these projects. It was from the very beginning to get them involved, to get them engaged, and then to also make sure, and the grant does this, it covers their time that they have devoted to Epic. The other thing that I thought was really important, and the only reason, not the only, one of the reasons that this was funded was because Epic came in as a partner. So Epic said, yes, we will build this for you and for these institutions, and we will work on this. So within Epic, that organization, they devoted staff to the rollout. And I think, so they have their own, we meet like, you know, once every 3 weeks or so, IS and IT within all of the sites and Epic meet regularly as well. So, you know, we have, you know, they are very much a partner in this whole process, and they actually attend all of the meetings of SIMPRO. Yeah, so that was it. So we weren't just saying, here's a request and just do it. You know, they actually had some input on how this rolled out, what were going to be some of the kinks, and what are going to be the workarounds, because they were really critical in figuring out what the workarounds could be.
That's terrific. And I think that having that Epic input is critical. And I think it's a good lesson for all of us that are trying to do research that does integrate into the EHR, is that it is easy to say, I'm going to create an integration. It's a whole nother thing to actually do it. So
yeah, especially I think in Rhode Island, where we're just so sensitive, and this is at Care New England when I was there, but also here at LISA, there's just this ultra sensitivity towards data security, patient protections, and, you know, the stability of the health record system. And, you know, they don't take kindly to like, oh, we want this integrated, but this one was Epic's going to build this. And I think that was an easier sell for IT here.
And did you actually get IT here to take money for it? Because my experience has been that they won't take contract related funding.
So they weren't, so LOCR, Kim Marie Lawrence is here, but the contract is with LOCR. They have time and effort devoted to the project, but it's not part of their contracted funds. Just like the nursing coordinator has, we contracted time and effort.
Stellar, that's helpful, thank you.
Yeah.
Kim Marie, if you have anything to add, I certainly welcome it.
Well, yes, that was very interesting to hear some of what, the work that we do on the, on the finance, research finance end, to really see the output at the end of the research. We don't often get to do that. So thank you very much. It's been very informative. And as far as IT, yes, it wasn't easy. We did have to really try to convince them, no, we want to pay you. And they're like, well, this is part of our job. And it's like, it is, but this is additional, this is different.
Yeah.
We will pay you for the time that you spend doing this. We will compensate your salary. And it was definitely challenging in the beginning to try to get them on board with it, but it's gone smoother now. And, I mean, understandably, as he was saying, it was part, they considered it part of their job, part of their IT job to do some of this, but it's like, no, this is different. This is unique, and we have the funds to pay you for it. So let's get this done.
Yeah. I think, Kim, also that actually helped. It helped certainly forge the commitment to the project on an ongoing basis, in my opinion.
Right. Well, I think also just knowing, you may consider it part of your daily responsibilities of sorts, but it really isn't. So, we really want you to do something outside of what maybe some of your projects as assigned sort of things, or duties as assigned, but, we're going to recognize you for it, acknowledge you for it, and compensate you for it.
Exactly. Yeah, I agree with Kim.
Others have questions? So I'll ask, so Don, where do you see this going next?
Well, what I want to see is whether or not clinicians and their teams find value in it, because I think we have the option to turn it off at 8 weeks in the surgical side. It'll be interesting to see if they just want to continue the project beyond the research term. And I think that's going to be really the key to say, well, I found this valuable, right? So I think within medical oncology, and I think Roxanne already is thinking about the same things I am, is, how can we start using this on some of our more, for some of the patients we're more concerned about. We have something called a high touch program now, where we identify patients who just came out of the hospital for toxicity, or who are frail but getting treated. And, we're seeing them 3 times a week. We're bringing them in 3 times a week for hydration, for infusion, for lab work. But this might be a way to reduce that clinical time, so we can monitor them proactively without having to devote so much, human capital into seeing them that way. So I think that's where the engagement can really be important. Not rely on them expecting to be called, but giving them the opportunity to actually get, to provide us some feedback. So whether or not we can get this to work in a high touch program, whether or not we can identify patients who probably should be in hospice sooner rather than later. And then I think, to what Rox's point, whether or not we can use this in the context of a clinical trial for better AE monitoring, I think it can be critical too.
I love that. And I'll say, kind of from my perspective, not being an oncologist, being either from my emergency medicine or my behavioral interventionist perspective, I'll be interested both in folks' perception of the utility of that information that's provided back to them, and in the day-to-day compliance. One of the things that we find in our studies is that folks are more likely to complete daily questionnaires if there's some perceived benefit. So if I'm just asking questions and not providing a clinical benefit, I have to pay them in general for the questions, right? If you're just doing like an ecological momentary assessment. And so the thing that I'm curious about here is whether knowing that you guys are seeing it is enough to motivate those kind of regular patient-reported outcomes. Like if you see a drop-off over time, what their perception is of that information and the callbacks that are received. And then to me, it's that next step of like, all right, where do you go? Like, so now you've shown that you can do it for the 8 weeks, you get this great data. Where's your next step of kind of an intervention, as you say, to kind of take folks that need high touch and provide it in ways that maybe doesn't overwhelm your clinical workforce quite as much. I think
Right,
it'd
and
be
I
really
think-
interesting to play with.
Yeah, I mean, I think just, how our team on the ground actually feels, did this help or did it just make their job more complicated? I mean, all of that is so important in terms of implementation sciences, and that's what I'm getting out of this whole project. Yeah,
Yeah.
I think it's really cool.
I
And
have one more question, if I may. I didn't
Go,
want
Roxanne. Yeah.
I had like a whole list, but I didn't want to keep going. So Don, if I'm a patient in dermatology and I have some sort of derm condition that I'm taking a drug for, psoriasis, just let me pick that one. And I'm also an oncology patient. Now, if I'm having a reaction, which is more common to the psoriasis drug, for example, and I don't know if this is necessarily a good example, would the dermatologist also get this feedback, or would it just go to oncology? So
No, it would just, yeah. So the way this whole program works is whoever's identified as provider is part of the way that this gets pulled in. So no one can have two providers pulling someone in. So radiation oncology, for example, they're not a listed provider.
okay.
But, so if I have a patient who's getting chemoradiation for cervical cancer, I'll get the toxicity reports, or my team will get those toxicity reports. And at the level of if it's severe or not severe, the expected phone call will come from my team, not radiation oncology.
And then you'll share with
Yeah.
the radiotherapist as you deem appropriate. Okay,
Yeah,
Right.
exactly.
thank you. I'll stop asking.
No problem. All right.
Any other questions before we let folks go? Let you all stand up and have a stretch break before your 2 p.m. Zoom or Teams or GoToMeeting or whatever today's
literally for the last 3 hours.
Yes. All right. Well, Don, this is, I have to say, it's just so awesome to learn more about kind of the work that you're doing and to get a better sense of, we'll have you looking forward to doing more of the Cosmos stuff too, but to learn more about kind of the day-to-day work. I think one of the things within CDH is that we have so many incredible folks that are doing so much neat stuff, and we just aren't fully aware of all of it. And so really
Right.
appreciate the chance to learn more about it, and it will help us better take advantage of and promote your stuff, and also will hopefully spur some new ideas on the part of the folks that are getting to listen. So thank you. Appreciate your time.
Yes, things like this are going to have such a home in CDH. I think this is going to be a great, place for all of us to just come and think about innovative ways to do things. So thank you very much, Megan.
Thank you. Well, I was going to say, and now we can send great students your way that have an interest in this type of thing too, if you want. So we'll have a talk about that separately. We've got so
Sounds
many
good.
lovely masters and doctoral students who are looking for learning opportunities. So
Yeah, definitely.
cool. Well,
Thank you very
all.
much for the chance. Okay, bye everybody.
Well,
Bye.
bye.